Welcome to the Registry Insider. I'm Bill Seifarth, CEO and Executive Director for the National Registry of EMTs. And on today's episode, I'm joined by Dr. Kevin Mackey to talk about an important initiative nationwide that he has recently had some successes with, and that's the Prehospital Blood Transfusion Program concept to implementation. So Kevin, thanks for joining me for yet another episode of the Registry Insider.
Thanks for having me, Bill.
So Kevin, you're a medical director for Sacramento Fire Department, correct?
Correct.
And have a pretty extensive emergency medicine and EMS background, a former paramedic yourself, a current paramedic, I should say.
Paramedic, just applied for my state license in California to get it back again.
Well, cool. Very good. So you can't get enough of this stuff.
Can't get enough. Love the pre-hospital space.
So blood transfusion program, that's the hot and sexy topic nationwide right now. And you have some successes with this, obviously, recently. So share with our listeners who may not know or who may be curious about what is a pre-hospital blood transfusion program. I think the name speaks for itself, but what's involved with it and what's the benefit of having it?
Well, I think the benefit is probably the easiest one to answer. I mean, when I was a paramedic, we carried saline. And when someone was in hemorrhagic shock, you give saline. And when that wasn't enough, you give more saline, right? And the challenge is, of course, I think the audience would know this intuitively, it's just saline doesn't carry oxygen. So when you lose blood, you should replace it with blood, ideally. Blood has many, many components, not just the least of which is a volume expander, carries oxygen. But it's intrinsically challenging to carry it. But the studies that we've seen, both through the military and the civilian environment, says that there is a 2% increase in mortality for every minute of delay of administering blood beyond 14 minutes.
And that's lessons learned, like you said, from the military.
Correct. Yeah, this comes, as all good EMS lessons, most of them came out of the military environment.
Yeah, very cool. So you recently implemented this or got approval for implementation of this within the last week or so. Share your journey, because I think a lot of people would be curious, what's involved in getting approved and getting a program up and started?
Well, I'm in California. So California is unique in EMS environment. We're not quite like Texas or Florida. But in our particular location, we went through the state first, and we went to the state to request permission for an expanded scope, because blood is not currently in the national scope, and it's not currently in most state scopes. So this is really done on the auspices of permission from the state to do a local optional scope expansion. So we did that first. To do that, you have to present the state with some facts. You need to present the state with how many patients are going to qualify for this. What does your protocol look like? And what is your relationship with your blood bank supplier? So we went through all of that, and then came the equipment. So we had the concept. We knew what the patient would look like, but then we had to look for the equipment. And the beauty is, there's a lot of really bad things that came out of COVID. One of the great things that came out of COVID is how to carry a product and remain at a constant temperature for a prolonged period of time without having to plug it into anything.
Oh, nice.
And so there's some coolers out there made by some manufacturers and companies that you can not only keep a product at a perfect temperature, 2 to 6 degrees Celsius, for 24 to 48 hours, but on the front of the device, it talks to the cloud and will communicate to your phone to let you know what the temperature is, so you can know if there's any excursions. So our journey started with permission of the state. Then we applied for a grant through UASI. UASI got us the grant because of our work with the military and with the local law enforcement. And then came the challenge, which is finding a blood supplier. And I think that's probably where most people find the biggest hurdle to implementation, is finding a supplier that is willing to share a blood supply or even entrust you with blood, even though they're going to take it back. And some of them won't take it back. And for most medical directors like me, I have a zero tolerance policy for waste. This is a precious component. Yeah. People are donating this blood, and they have an expectation that this blood is going to be used to save someone else's life. And I think it's medically irresponsible to take this blood that someone has donated and to not use it.
Yeah. Makes sense. So big hurdles to overcome. that last piece, that collaboration with the blood donor center was key. Clearly, it sounds a lot like which everything else in EMS is a true systems approach. You need the hospitals in the region and the trauma centers in particular to buy off on this. You need the blood center. You need to have buy off from your operational elements, whether it be fire departments, EMS services. There's one piece we haven't talked yet, but the education. Obviously, a large percentage of our audience are educators or educators at heart. Tell us a little bit about how did you prepare your medics? Because I mean, I know when I was educated, we didn't learn about this. Granted, it was in the early 90s, but still, this was not part of our core curriculum nor part of the educational experience for most medics out there. What did you do to kind of cover that gap or address education?
I think if you look at most programs through the country, for our fire department, we have roughly 225 paramedics. I have no plans to train all 225 paramedics because I don't think that this is such a delicate skill and it needs to be done perfect every time that you shouldn't spend the time training 225 paramedics because the vast majority may never use this.
Yeah.
So we identified a core. And I think that follows the model of the New Orleans program, which is one of the oldest programs in the country, been around the longest, and San Antonio, Texas. So we followed their model where they have very specific individuals that are trained. And what I did is I brought them in and we went through everything soup to nuts blood. What is blood? What are the types of blood? What are the kind of blood that we're going to be carrying? What are the criteria for a patient that's going to receive this blood? Because just because you may be shot 9 times doesn't necessarily mean you need a transfusion right away. You're probably going to get one. But does it mean that you need one? Is the time difference between getting it right then versus the hospital going to make that downstream difference in mortality? So we have very specific criteria. And then we looked at the equipment. And I think that's where the biggest uphill climb is for educating the individuals, because this is new equipment. We don't carry coolers typically in the pre-hospital environment. This is a daily operation. This is a daily check, much like we do with narcotics. It has to be done in a very prescriptive and very precise way. And then the administration, the equipment to administer is also something that we've never carried before. Blood tubing has to come. It's a Y tubing. There's saline that comes into it. There's blood that comes into the other side. There's filters. A lot of programs in the country use warmers. We are not using warmers. And we just made that conscious decision to not use warmers up front. And then training them how to hand off at the hospital, which is also like hand off at the hospital. This is what we do every day. Not like this. This is a little bit different. So, because this individual needs to be watched for transfusion reactions, not only during transport, but also when you arrive at the hospital and beyond. So what happens if this individual develops transfusion reactions? You need to alert the hospital staff to this individual's received blood. And there are potential downstream complications from what we've done in the pre-hospital environment to keep their eye out for. So all of that was part of the education.
So a lot of education, that kind of the nuts and bolts apparently seem to be the most difficult part. The probably the physiology or the anatomy aspect of it is relatively straightforward because medics learn that in their core curricula. What do you do now from a quality assurance and an oversight perspective, especially from the medical director's point of view, going forward? How do you review this? How do you ensure continuous quality with the program?
We look at a lot of things, first of all, from patient selection, and did this patient meet the selection criteria? And then as we go on further, we look at the actual administration, complications of administration. But even stepping back from that even further, this is a daily operation on my part to make sure that the blood's being checked. I have it on my electronic devices. And so I can actually tell when the cooler's been opened or not. So I can tell it, at 10 o'clock in the morning, if one of our units hasn't checked their blood, maybe they had a busy night, maybe they're on calls all morning, but it's just a quick phone call to remind them, hey, don't forget, we got to check the blood today. So it's stepping back and making sure that if the blood is needed, my most important role, the first most important role, is making sure that the patient that needs the blood at that moment is going to receive blood that has followed all of the quality checks from the moment we picked it up from the blood bank all the way down until it enters their vein. And there's a lot of steps in that process. And that's where I think a medical director needs to have a very close and watchful eye so that we don't get to that patient that needs the blood and, right. Yeah, we can't give this unit of blood. It's gotten to be too warm. It wasn't handled properly. So,
yeah. Okay. That's good to know. That's good to know. So you had mentioned New Orleans and San Antonio as far as historical programs. Are there other kind of lessons that can be learned from programs, or perhaps lessons that you've learned other than persistence and patience, clearly based on what you said? Other lessons that folks could learn if they're interested in doing this?
Sure. I think that probably the best resource, honestly, and I'll send the viewers to this, is prehospitaltransfusion.org.
Perfect.
So this is led by the prior NHTSA director for EMS, John Kramer. John is been spearheading this project, and currently, if the viewers didn't know, we have about 300 programs up and running in the country that are doing pre-hospital transfusions. So when I first had the conversations with my local blood banks, they're like, what? Until they started to realize, oh, so this actually can be done. So I would send the viewers there first. That has all of the science. It has connections to individuals that are doing this successfully already. Honestly, I'll be honest with you. Some of the reasons for my success are because the individuals that are part of that organization. I just be blunt honest.
Prehospitaltransfusion.org.
Prehospitaltransfusion.org. I reached out to the New Orleans program, to Eric Bank. I reached out to CJ Winkler in San Antonio, and I said, hey guys, we're thinking about this, and you're going to find a lot of friends that want to come alongside you and get you to success. They were my encouragers in the darkest moments of getting this thing off the ground, because as a clinician, I know this is needed. I know it's going to work, especially in in an urban area like Sacramento. We have some violent crime. And by the way, I want to mention that pre-hospital whole blood, or I said whole blood, it's not always whole blood, right? There are other components that programs are carrying. Some are carrying packed red blood cells, which have plasma in it. Some are carrying just plasma. Some are carrying whole blood. So there's a lot of varieties to carry. But when I was in the dark moments of this, I could reach out to these friends and they would say, just be persistent, be persistent, be persistent. And as you mentioned, recent success, my success is less than 7 days old. I finally, through persistence, was able to work with a local supplier that said, okay, we're going to do this.
Excellent. Well, anything else you want to add regarding your successes?
I think not just necessarily my successes, but if you're really thinking about doing this, if you're a state regulator and you have systems that are thinking about coming up and running with this, there is tons of literature out there on the regulatory side. I would direct you to AABB's website. So this used to be called the American Association of Blood Banks, and it's now called the Advancement of Blood and Biotherapies. So it's so it's kind of cool. They kept the same acronym but changed the name. So I would direct those individuals to there. There's actually regulatory documents out there now about how to administer whole blood. This is from the blood bank side. Blood banks are highly, highly regulated. States are regulatory. So this is a good place to start if you're a state regulator. If you're an educator, there's scads of literature out there now about it. And this prehospitaltransfusion.org is another good place to connect with educators in these systems like New Orleans, like San Antonio, like Detroit, like Washington, D.C. Some of the stories, Washington, D.C. really sticks out in my mind because I was on an Eagles call and Washington, D.C. had just implemented. And usually you think, yeah, I've done the math on this. This is going to take maybe about 3 weeks before we give our first unit. Washington, D.C., the first day.
Really?
First day within hours. Some programs have just completed their training and 2 hours later are administering blood in the field. Again, these are patients, but I was starting to say earlier, what I do want to drop off also with the folks, this isn't just for trauma. We need to start wrapping our mind around hemorrhagic shock as not being just around trauma. This is also postpartum hemorrhage. This is GI bleeding, right? This could be that dialysis patient that's leaking from their catheter. that wakes up in a pool of blood and is exsanguinated 3 or 4 units of blood into their bed and didn't know it. But those patients have happened too. If we can get blood into the veins of these individuals, they go from a very shocking near-death state by the time you arrive at the hospital, sitting up, awake, talking with stable vitals. It's awesome.
It's really a lifesaver.
It's truly a lifesaver.
Excellent. Well, Kevin, thank you as always for what you do for us at the National Registry, and certainly for locally at your fire department and nationally with your other hats on in the EMS world. So, and congrats on the success with your blood transfusion program.
Thank you, Bill. Thanks for having me.
And thank you as well for joining us. And as always, stay safe. Thank you for joining us for this episode. If you wouldn't mind, please click the like and subscribe buttons, as well as the notifications so you can get notifications of upcoming episodes. Also, for the latest and greatest happenings of the National Registry, feel free to go to nremt.org. Thank you very much. And again, stay safe.